Good afternoon, everyone. Thank you so much for joining us. If you have the ability to change your name uh, on your Zoom square, please go ahead and do so. Because of a technical glitch, there's everybody is named after one of our former colleagues. Good afternoon. My name is Amol Sinha. I'm the executive director of the ACLU of New Jersey. It's my great pleasure to welcome you to Raising the Bar, Defending Abortion Access in New Jersey. Since our founding over 100 years ago, the ACLU has been an essential part of the fabric of American life. Here at the ACLU of New Jersey, we utilize a model called integrated advocacy, using all of our tools in our toolbox to achieve our transformative vision for the future. This includes impact litigation, legislative and policy advocacy, community organizing, public education, and strategic communications, all coming together in harmony to improve the lives of all New Jerseyans. And we do this across many issue areas, including racial justice, immigrants' rights, criminal legal reform, LGBTQ plus rights, economic justice, and of course, abortion access and reproductive freedom. Indeed, advocating for reproductive autonomy has been a part of the work of the ACLU since our founding. Whether it was defending the distribution of birth control literature in the 1920s, or being a part of the team of litigators on cases that secured abortion rights in the 60s and 70s, fighting for abortion access has been a part of our DNA. Since the Dobbs decision overturned Roe v. Wade nearly a year ago, the landscape for reproductive rights and access to abortion has been upended. This devastating decision and the abortion bans that followed are the results of a decades-long coordinated effort rooted in control, misogyny, and racist policies to strip away bodily autonomy and to further marginalize the already vulnerable. Just days after the midterm elections, in which voters overwhelmingly demonstrated support for abortion rights, on November 18th, 2022, several anti-abortion groups sued the U.S. Food and Drug Administration over its approval of mifepristone, one of the two drugs most commonly used in medication abortion, which accounts for more than half of all abortion in the United States. We'll hear more about the mifepristone case and other pressing issues shortly, but whatever may come, our state must be ready. These assaults on the rights of the people to make healthcare decisions are not going to stop. The ACLU of New Jersey and our coalition partners are using every tool available to protect and defend access to abortion and other reproductive healthcare, including legal and regulatory advocacy, legislative campaigns, and public education. The Dobbs decision intensified the inequities in access to healthcare. Access to abortion is a racial justice and economic justice issue, and barriers to care disproportionately harm communities of color, undocumented community members, and reinforce existing inequities. New Jersey took action to safeguard the legal right to an abortion by passing the Freedom of Reproductive Choice Act in January 2022, but we can and must do more. It's imperative that our lawmakers take immediate steps to ensure abortion is not only legal in New Jersey, but also accessible and affordable. As part of the Thrive Coalition, the ACLU of New Jersey is pushing for lawmakers to expand access to abortion in our state by passing the Reproductive Equity Act. And during today's program, you'll hear from some of the foremost reproductive rights experts who have partnered with the ACLU in this fight for abortion access. Before we get started with the program, I want to take a minute to thank our lead sponsor, Lowenstein Sandler, without whom this event would not be possible, and who's also serving as our CLE provider for the event. So thank you so much, Lowenstein. Many thanks to our other sponsors, including Barry Corrado and Grassi PC, Chiesa, Shahinian, and Giantomasi, Gibbons PC, and Pashman, Stein, Walder, and Hayden. And a big shout out to our wonderful partners and friends at NJ PAC, who are the ones who are producing today's great event. And with that, it's a great honor to introduce you to the individual who leads our legal advocacy at the ACLU of New Jersey, my dear friend and colleague, ACLU-NJ's legal director, Jeanne LoCicero.
Thank you, Amol. And I'd like to welcome everyone and thank you all for taking the time to learn more about abortion access in New Jersey and across the country. I've been looking forward to this conversation for the past 2 months, and I'm really excited to get us started. We've pulled together an amazing panel, and their full biographies are in the CLE materials, but let me give you a little bit of information about each of them. First, we have Dr. Kristen Brandy, who is an obstetrician gynecologist with expertise in contraception and abortion services. She's the board chair for Physicians for Reproductive Health and has been a leader in educating the public and lawmakers about the impact of anti-abortion laws and policies and how the impact on providers and patients. Next, we have Lauren Johnson, who has spent her career as a public defender and civil rights advocate, and earlier this year joined the National ACLU as the director of its newly created Abortion Criminal Defense Initiative. And she'll be leading efforts there to knit together criminal defense expertise with the expertise in protecting people's reproductive freedom. We also have Kim Mutcherson, who is a nationally recognized reproductive justice scholar and currently, at least for the next couple of weeks, co-dean at Rutgers Law School. And she'll be returning to law professor life when she ends her term in June. And then we also have Catherine Weiss, who is the chair of the Lowenstein Center for Public Interest. And earlier in her career, Catherine led reproductive rights litigation at the National ACLU, and that really put her in a terrific position to lead a team of lawyers to provide pro bono guidance and support to New Jersey reproductive healthcare providers, patients, and helpers. And so I want to thank you panelists for joining us this afternoon. For those of you on who will be seeking CLE credits, I will be announcing 3 codes throughout the program. You'll need to complete the evaluation form with the codes by next Tuesday, May 30th, and shortly a link to the form will be provided to you in the chat. So panel, we know that Dobbs versus Jackson Women's Health Organization was an unprecedented attack on women's rights and reproductive freedom. And while New Jersey has legal protections for reproductive autonomy, we saw a flood of activity in states hostile to abortion rights. I saw a number that last year there were 430 laws introduced to restrict or ban abortion care. And we know that this has resulted in total bans on abortion in 14 states and severe restrictions in several others that are functional bans. And we see headlines every day about actions in states to further restrict access. And this is impacting tens of millions of people across the United States, including here in New Jersey. But we also know that those efforts to restrict abortion didn't begin with Dobbs and are not just about abortion, but about bodily autonomy. And so with that, I'd love to turn to you, Dr. Dean Mutcherson, and as someone who is a legal scholar who studies reproductive health and autonomy, could you start us off by giving us an overview of the movement for reproductive justice and why that framework is important in understanding the rights and issues at stake?
Absolutely. So first of all, Jeanne, thank you so much for collecting us together to have this conversation today. I'm very excited. Second, Kristen and I did not coordinate, even though it looks like we're wearing a very similar blouse. It's just an accident that happened. So I love talking about reproductive justice because I think that it has often been used as being a synonym for reproductive rights, and it's not. So reproductive justice is a movement that was started by Black women in the mid-90s. These were folks who were activists in their communities and were doing all sorts of really important work, and who found that the mainstream reproductive rights movement, which was very focused on abortion, very focused on the idea of choice, was not thinking deeply about issues that were relevant to women of color, particularly Black women, low-income women, women in the South, all those sorts of things. And so this group of founders came together and decided to form a movement that was, one, going to be rooted in the experiences of women of color. So it's very intersectional. Two, that was going to be based on human rights as opposed to sort of constitutional rights and civil rights and the way that we think about them here in the United States. And that was going to be much more fulsome in thinking about people's lives. And so reproductive justice has 3 tenets. It says that women have the right to decide if they will have a child. Women have the right to decide that they want to have a child. And women have the right to decide women have the right to raise their children in safe and healthy environments. So right to have a child, right not to have a child, and right to raise your children in safe and healthy environments. And the reason why I think that framing is so important for any discussion about abortion is that when you're talking about abortion, you're never just talking about abortion, right? You are talking about all the ways in which this country has controlled, inhibited procreation and parenting often for people of color, but also people living with disabilities, for people who are undocumented, for people who are incarcerated. So I always say that when I'm talking about abortion, I am talking about everything from affordable childcare to criminal justice reform, to access to good public schools, to access to clean water. All of that is a part of thinking about what it means to be able to have a child in this country and to raise that child.
Thank you. That's a really helpful framework to kind of think about the spectrum of issues that are part of what we're talking about today. Catherine, I want to turn to you because earlier in your career, you were leading litigation to protect access to abortion when Roe was still the law of the land. And can you share a little bit about what that was like?
Sure. You know, I'm happy to do that. I think that the headline here is that it was much better than this. It was much better than what we have now, and it still wasn't very good. And that's because the framework of the protections in Roe were under assault from the moment that they came into existence in 1973 and before. And they stayed under assault throughout the entire history of that doctrine. And so, you know, we faced sort of overwhelming attacks on the core right of people to choose whether or not to carry a pregnancy to term for decades. And on many occasions, we believed the Supreme Court would overturn Roe. We believed that in 1989. We believed it in 1992. There were many, when Webster was in 1989 and Casey was in 1992, there are many people in the audience will recognize these landmark decisions. And at each stage, we thought that we might lose the right altogether. And in many ways, in many ways, we did for large swaths of the population. So starting in the 80s, the Supreme Court upheld something called the Hyde Amendment, which denied low-income women Medicaid funding for abortions at the federal level. And that meant that low-income women couldn't access care, whether they had the right or not, in many situations. And at the same time, parental involvement laws swept the country, which meant that teenagers couldn't access care in many places. So we started losing this right almost as soon as we gained it. And that, and you know, the litigation that I engaged in then, starting really in the 80s and early 90s, was at the state constitutional level, in part because the federal right was under attack, and the most we were going to do was preserve the right. We were not going to expand it at the federal level. That was very clear from early on. So that's sort of an overview of the history of this litigation at the federal level. Yeah.
Yeah, there are two things that come to mind. One of them is how a lot of times we're talking about Roe today, like it was great. And I think it's important to remember that it was flawed from the start. And so when we think about our vision for the future, I think that helps and, you know, can help inform what we want from that. But then you also touched on the state constitutions. And I know you led one of the lawsuits here in New Jersey regarding our state constitutional protections to abortion rights and privacy. And can you talk a little bit about the New Jersey landscape when it comes to constitutional protections?
Yeah, New Jersey's been interesting, you know, because we have state constitutional decisions on reproductive rights all over the country. Well, when I say all over the country, I mean on the coasts and in certain states that are not on the coasts. And New Jersey has a sort of unique position here First of all, it relies on language in the New Jersey Constitution that is not like language in the federal Constitution. It's really nothing like language in the federal Constitution. It's how the state constitution begins, and it's an individual rights clause that does not have a federal parallel. So from the get-go, they're looking at language that doesn't parallel the language on which the federal right rested. And then, interestingly to me, the court has been really fixated on equality in its reproductive rights decisions in New Jersey, but not on equality, not on gender equality. What they've looked at is discrimination between different classes of people who need abortions, or who need reproductive health care. So, for example, the first state constitutional decision in New Jersey had to do with Medicaid funding, whether the state would be obligated to pay for medically necessary abortions for low-income people after the federal contribution had been cut off. And the court said yes, that the state was obligated under the state constitution to use state dollars to help low-income women pay for abortions. And that decision was based on discrimination between those for whom medical care was necessary for an abortion and those for whom medical care was necessary for childbirth. And the court held that discrimination between those two groups was invalid. And when they reached the case that I was involved in, which involved a parental notification bill for abortion, law for abortion in New Jersey, they did the same thing. They said that it was unconstitutional to discriminate between minors who needed abortions and to require them to involve their parents, while allowing minors to consent on their own and without their parents' involvement to services related to delivery and childbirth, which is far, far more medically risky than abortion. And the court said that discrimination was invalid. So New Jersey has a long history of looking at how regulation affects different groups of women needing different kinds of care and invalidating discrimination between those groups of women.
Thank you. So for decades, we've had these constitutional protections in place, but we didn't have any explicit laws on the books about abortion and rights to abortion until last January. And as Amol mentioned, in January of 2022, with Dobbs being argued and pending before the United States Supreme Court, New Jersey enacted the Freedom of Reproductive Choice Act. And that state law makes clear that all people in New Jersey have the right to make a range of reproductive autonomy decisions, including regarding abortion and contraception and whether to give birth, whether to be sterilized. And it has some terrific policy language about our state's public policy in support of those rights. And I just want to lift up again our Thrive Coalition, who worked for years to get that law passed, and thank the lawmakers who made that happen. It was a great first step in codifying rights, but as we're going to hear today, there's a lot more to do to ensure that the rights don't just exist on paper. I'm going to read the first CLE code, which is 307277. So the CLE code 307277. And want to remind folks, I forgot to mention at the beginning that we are accepting questions through the Q&A feature on your Zoom. And so please, you can submit them there and we will work our way through them. We're hoping to have time at the end and might also incorporate them into our discussion today. So then Dobbs kind of comes on the scene, and Dean Mutcherson, I'm hoping you can lay out what the Supreme Court ruled in Dobbs so that we're operating on the same page.
Yeah, I want to, Catherine sort of alluded to this, but I want to just sort of be a little bit more explicit about what Roe and Casey said, because I think it's important to understand how substantial this shift was in what Dobbs did. So in Roe, the court said there was a fundamental right to an abortion. Haven't heard that language since, but we got it in Roe. The court said that a fetus is not a constitutional person. The court said that the state has an interest in potential life, but didn't sort of quantify that interest. And then they gave us the trimester framework. So first trimester, none of your business. State, you cannot regulate. Second trimester, you can regulate to protect the health of the pregnant person. Third trimester, you can go as far as to ban abortion, but you always have to have an exception for the life and health of the pregnant woman. Then we got Casey in 1992, which was a substantial rollback of Roe, and the court essentially said, we did not give enough credit to the state's interest in potential life. So now we're going to do that. Threw away the trimester framework. So we're just going to focus on viability, which of course is a shifting line to focus on. But we're going to focus on viability. And so you can regulate throughout pregnancy because the state's interest in potential life starts as soon as somebody becomes pregnant. That's what the court told us in Casey. And they also said that the state, because it has this interest in potential life, can actually work to get women to decide not to have abortions, right? So that's why we got things like bias-informed consent requirements, waiting periods, all of that stuff is flowing out of Casey. But we still had a court that was saying a fetus is not a constitutional person, and we still had a court that was saying, even if you ban, you have to have an exception for the life and health of the pregnant woman. And then we got Dobbs, and Dobbs was basically the majority of the Supreme Court saying, precedent is for suckers, stare decisis is for suckers. We're just going to do what we want, and essentially said there is no longer a federal constitutional right to an abortion. We're just going to send it back to the states, and the U.S. Supreme Court is going to get out of the business of abortion, which was laughable at the time, and they knew it, right? There were always going to be cases that came back to them. But basically, they said to the states, do what you will, right? So even some of those backstops that we had in place, things like you have to have an exception for life and health, that's out the window. The idea that a fetus is not a constitutional person, that's no longer sort of sitting there as a backstop any longer. And the consequence, of course, of that is that lots of states, some already had laws on the books that said as soon as Roe falls, abortion is going to be illegal in our jurisdiction. So they were ready. And then other states moved very quickly afterwards to amend their laws or to pass new pieces of legislation. So as you said in the beginning, we've got about 14 states that have bans of some sort. A lot of those bans are based on gestational age, which is, I'm sorry, we'll call you Dr. Brandy, not Chris, sorry. I'm sure Dr. Brandy is going to talk about this, but these sort of gestational limits that are kind of all over the place and that make no sense whatsoever, mostly criminalizing people who perform abortions. But if you think that that's where this ends, then you're being woefully naive, because the possibility of self-managed abortion, particularly with medication abortion, which I know we're also going to talk about, means that eventually you have to go after the people who are actually having abortions. You can't just go after the healthcare providers. So where we are now is chaos. It is absolute chaos. And chaos is kind of the point. And the reason why I say that, and then I'm going to stop talking, is one of the most powerful things that has happened with the legislation that has passed, is that because healthcare providers don't know what they can do, they will do nothing, which is not an indictment of healthcare providers, right? If you don't know whether the abortion that you are about to perform falls within a medical exception where no one has actually defined what that exception means, then you're not going to provide that abortion at the risk of going to prison and potentially losing your license to practice medicine, which means you can't provide healthcare to anybody any longer. So we are in a very, very bad place, and it's only going to get worse from here.
Yeah. Dean Mutcherson, you mentioned self-managed abortion, and I was wondering if you or Dr. Brandy could say a little bit more about what that means in the broader context.
I'm going to toss that to you. Is that okay?
Yeah, no problem.
Okay.
Hi, everyone. Thank you for having me. So self-managed abortion is people obtaining or utilizing things that they have at home in order to have an abortion. So this is doing this outside of the typical healthcare system. This often looks like people getting pills mailed to them from different organizations. It can be herbal medications. It can be physical actions that could cause an abortion. So again, doing so in a way that is not engaging the healthcare system at all.
Gotcha. Thank you.
Mhm.
So Dr. Randy, you've been on the front lines of providing care as this chaos has unfolded. Can you tell us how the Dobbs decision and its aftermath is affecting patients seeking care in New Jersey and those getting care from out of state, getting care here in New Jersey from out of state?
Yeah, and I think Dean Mutherson framed it well in that it is chaos, and chaos by design. That I say this a lot, and I said it a lot pre-Dobbs, but really it's true now more than ever, is that really healthcare is now determined by your zip code based on where you live. I'm very fortunate to be an abortion provider in New Jersey, where I can provide care that's protected by our government. But it still leaves a lot of questions, and there's a lot of impact that is happening on a federal level, which we'll talk about in a little bit. But I really like this phrasing that you said about patients seeking care in New Jersey and people getting care from out of state. I think there's been a lot of conversations about haven states and banned states. And I think that minimizes the issue. It makes it seem like there are some places that are safe and places that are not safe. And there's definitely places that have more bans than others, but I try to caution people that there's no safe state right now when the government can decide who can get care and who can't, whether that's gestational age limits, whether that's bans on certain procedures or medications. It's really concerning to me about how care really differs depending on where you live. And so currently for people in New Jersey, luckily, we're still able to continue to provide care, medication abortion, procedural abortion. We do not have any gestational age limits in our state, which means that we can provide this full spectrum of care to whoever shows up at our door. The problem with the Dobbs decision immediately afterward is because we are now starting to see people from out of state, it's causing our healthcare system in New Jersey to be overwhelmed. And so we are currently seeing wait times in clinical spaces and hospital-based care where people both living here and people that are coming from out of state are having to wait a couple weeks to get the care that they need. And that's a big problem for people that are pregnant because we know that, pregnancy doesn't stop based on when you decided to get care, and time is of the essence, depending on what kind of care that you need. I also just think it's really disheartening to hear all the stories from people getting care out of state. As a provider in New Jersey for quite a while now, I saw patients occasionally from New York or patients from Pennsylvania, but I'm seeing people from across the country now getting care in our state. And stories about figuring out how to get childcare and time off of work, having to either drive hundreds, thousands of miles to get somewhere, having to figure out how to get a plane ticket if they're flying. Sometimes abortion takes multiple days of care. And so how do you figure out where to stay or who to stay with, or if I can afford a hotel room or sleeping in my car? It's been really heartbreaking to hear the stories of people that are traveling from other states to get the care here. And these are people that can make it here. There's a lot of people that unfortunately for a lot of different reasons won't ever get that care. And so it's been a really challenging time to be able to provide care. But I'm really glad that I'm able to do so as best as I can right now in our current state.
Yeah, and thank you for all of what you're doing on that front. We've had conversations before. Can you talk a little bit about how abortion restrictions are impacting other types of care? And for example, I know miscarriage management is being really impacted by some of the restrictions.
Mm-hmm. Yeah, and I think many people don't necessarily recognize all the links between abortion care and other types of reproductive health care. As an OBGYN, I take care of people for a lot of different reasons. And a lot of the management that we use, the medications we use, the procedures we use are very similar depending on the circumstance. So like you mentioned, for miscarriage care, miscarriage management, the medications are the same as abortion care. The procedures we do are the same as abortion care. And so any type of ban that may restrict a medication or may restrict a procedure like D&E that we've seen recently in other states, that impacts people's ability to get miscarriage. And we've seen that through the stories of people in the news, it feels like every day now, talking about how they had some type of pregnancy complication. They broke their water early. They're having bleeding during pregnancy. They themselves, their health is at risk with their pregnancy. and they can't get the care that they need, even if it is in a situation around miscarriage or a pregnancy complication, because abortion bans don't necessarily have the best language in those laws and make it very vague and very confusing for providers that don't necessarily understand if the procedure that they're trying to perform for this circumstance is allowable or not. Some states, it's very clear that it's not allowable, even if it's things like managing ectopic pregnancy, which are life-threatening. Places like Tennessee that have an affirmative defense, you have to break the law first and then try to defend yourself. And so it's really scary for a lot of providers that are trying to provide this care. We've seen also impacts in other types of care, things like infertility treatments, IVF, where we're managing embryos. And if embryos are destroyed or damaged in some way, is that also going to create problems with abortion bans? Concerns around contraception being the next thing that's targeted. It's been a really challenging time to be a provider. And I know that there's a lot of us that have a lot of moral injury because we have been trained for years, for decades, to be able to provide the best care that we can for our patients. And there are laws and things that are not really related to the evidence and the science and the medicine that are preventing us from doing, providing the best care that we can for people. So it's really frustrating.
Right. Dean Mutcherson, I saw you nodding. Did you have something to chime in on?
No, I'm just an active listener.
Oh, okay. So, Dr. Brandy, you mentioned a lot of the risks that doctors are facing, and so Lauren, I'd love to turn to you. We know that there's a lot of criminalization happening across the country regarding abortion care, and you're leading this new abortion criminal defense initiative, which I understand is part of a larger effort to provide criminal defense support to people who need it, providers, patients, and those who are helping folks. Can you share more about how the project came to be and what your vision for these efforts are and what's underway?
Sure. I guess just to take a step back and to talk about kind of how this all came into place. The conversations that happened predated, the decision in Dobbs. And like as to Catherine's point, these conversations were happening many years ago because of recognizing the vulnerability of the Roe framework from the very beginning, and seeing that at some point it could be possible that these that people who are just trying to access or provide this care would now have to deal with a very confusing and challenging legal landscape and the risk of criminal penalty. And so before the decision came out, a number of reproductive legal organizations, including the ACLU, were collaborating and coordinating and thinking about a centralized response. And so out of that came the Abortion Defense Network. And that's a kind of umbrella network of organizations that are trying to respond to various specific needs that are now facing providers, helpers, and patients. And so we raised our hand for the criminal defense response part of that larger work and that larger support. And that's largely drawing on the existing deep expertise we have in reproductive freedoms advocacy, as well as criminal legal reform advocacy, and also the existing affiliate network that we have where we can be in community and collaboration with folks who are closest to the harm, to the providers, to helpers, to patients, to directly inform and work together to have a response. So with regard to the ACDI, we are working twofold. Number one, to be ready in the instance of prosecutions and investigations. That's the biggest part of work that we're doing in the short term. And that is to make sure, number one, that providers and folks who are accessing care know that they're not alone, know that there are people who are ready, skilled, capable, experienced, values-aligned folks who are ready to support them in this journey if they face it, who can help advise them before the point of prosecution and help guide that path. Another big part of it is trying to make clear to those who are motivated, prosecutors, to know that if they are deciding to take these steps to prosecute people, that they'll be met with the full force and might of very engaged and ready defense attorneys, and also the might of the ACLU and our other partners. And so that is kind of one of the first focus is being ready in the event of prosecution. But the secondary part is obviously trying to not only prevent prosecutions, but do something to reduce this harm. The chill that Dean Murchison has talked about and Dr. Brandy have talked about is so pervasive. And so we're trying to think about how can we work within the existing framework to help providers have more, in this very difficult landscape, a little bit more peace of mind, that they have been able to think through the decisions in ways that they can mitigate their risk while being able to provide some of the care that they wanted to provide or that they were able to provide in the past. How can we support creative care ideas, recognizing this, this current legal landscape? And then also, how can we work with local actors to reduce harm in existing frameworks? So, for example, for incarcerated folks, for people who are systems involved, what policies or tweaks could be made to try to not at least make it harder for them to access care in this already exceptionally challenging moment? So that is the secondary, but also very important part of our work, is thinking affirmatively about how we can support the work that's already going on and reduce the harm in this existing moment.
And so are there, can you give us a sense of the criminalization efforts that are taking hold, or what kinds of responses are needed at this moment?
Sure. So we haven't seen that many prosecutions. I think some people were surprised by that. I don't know that I would say that I'm one of those people. I think here, so much power comes from the threat of prosecution, from even the suggestion of the bill. And understandably, providers are scared. They're now having to navigate the risk of criminal penalty, of going to jail for providing care. And they're not getting a lot of guidance. And there aren't a lot of clear answers, right? And so in that moment, prosecutors don't have to actually bring charges to get what they're trying to get, which is to chill, to stop access to care, to make people, to drive people further underground as far as getting the help that they're trying to get. Another aspect of this is, I think, that whenever prosecutions come, certainly they're not going to be out of coincidence, right? It's very likely that these will be tactical efforts, intentional prosecutions that are brought. And so we're trying to make sure that when those do come, we are fully ready and fully prepared and coordinated, but we haven't been seeing that many at this point. What we have been seeing is that the mechanism is working, or is starting to move, right? So we have been reached out to by providers or people who may have received a subpoena or had a detective contact their staff, or when they were arrested on an unrelated charge, having been questioned about their recent medical care related to abortion access. So these are the ways in which people are reaching out to us, and we're trying to get involved at that point to advise them. We're also doing some work, as there have been so many changes in the laws, right, that impact the day-to-day, in the moment decisions that providers are making, trying to get in there to help them navigate that as it's happening, and trying to strategize with them, informing them of the risks, but also helping them think about the dynamics and how they might be able to creatively still provide care while protecting their own practice. And so that is the way that we've seen more of the needs come up, in addition to, if there are places where it seems like their own practice is being investigated, helping advise at that point as well.
I'm so glad there are people like you doing this work and trying to coordinate these efforts, because every day there are headlines about the kinds of care that's unavailable, or the chilling effect everyone's been talking about, and the really dire consequences that patients are facing.
Can I just weigh in on that? Because, I think that understanding what the threat of prosecution does in this space is a really important thing. And so I'm just going to tell a story about a case that arose in New York in the early 90s. And I'm just going to repeat that: in New York City. We're not talking about Alabama or Mississippi. And so here's what happened. I get a call from, I'm a reproductive rights lawyer at that time at the NYCLU. I get a call from a doc who's practicing at Montefiore, a hospital in the Bronx. And there's a patient who's come in who is post 24 weeks. Now, at that time, New York had a pre-Roe abortion law that said that abortion was illegal after 24 weeks, even though under Roe, there had to be life and health exceptions. But New York law didn't have them because it had never amended its statute after Roe. Okay, so we have this law that is not really enforceable sitting on the books that says abortion is illegal after 24 weeks. Meanwhile, a patient has come in and she has uncontrolled gestational diabetes. That means that she's unable to control the blood sugars, and she's in diabetic crisis. They do tests and they find that the fetus she is carrying, which is, I think at that time, 28 weeks, has trisomy 13, which is a genetic anomaly that is incompatible with life. This fetus, when born, will die. The doctor, understandably, wants to end the pregnancy so that this person can stop being in diabetic crisis and go home to her, to the toddler that she has at home. And the hospital council says, no, it's illegal in New York. After 24 weeks, you can't do it. And forbids the doctor to do the procedure. Whereupon a whole lot of things start happening. Well, you know, I get on the phone with hospital counsel. I tell him that this isn't enforceable. He doesn't care. He's like, my job is to prevent legal risks to the hospital. We're not allowing this. And she's, I should mention, hospitalized. She's in diabetic crisis. She can't leave. She can't be like, I will go somewhere else for my care, right? She's in diabetic crisis. And we had to get the Bronx DA to write a letter to the hospital council saying, if you do this, we will not prosecute you, before they would let this doctor proceed. This was New York City when Roe was in place. And so just picture what that means for people practicing in a state where it is now illegal. I mean, this is why you're getting patients sitting in their cars in the parking lot, waiting for their conditions to become life-threatening so that the life exception will apply, right? So that they can get care. They're waiting till they go into shock before they will provide care because of the threat of prosecution. And that is very often when a woman is very sick, out of the hands of the treating physicians who are desperate to help, and in the hands of hospital counsel who view their role as protecting the hospital from potential criminal liability. And so we have, so sort of understanding what it means, having somebody in Lauren's position who will get on the phone and get the prosecutor to say, don't leave her in the parking lot. We'll treat this as life-threatening now before she goes into shock, right? So that people can get the care is just incredibly important, because there'll be immense barriers to people getting the services that they need.
I want to jump in and just reinforce what both Lauren and Catherine were just talking about. Part of what we're hearing, and I will take on this responsibility as lawyers for the role that we are playing in this. But part of what hospital counsel is saying is, I can represent you in a malpractice suit, but I'm not going to represent you in criminal court, right? And we know how to handle the medical malpractice. We don't know how to handle what happens if you get prosecuted. So that's one thing. And your insurance certainly isn't going to help you out on that either, right? Because they're not going to cover criminal activity. So hospital lawyers are notoriously cautious, and I don't think anything about that is going to change necessarily. The other thing that is really, really painful, and there was this amazing ProPublica article, and I'll find it and I'll put it in the chat so people can see it. But it was about a woman, and she had a very difficult pregnancy that was, potentially life-threatening. And there was a physician who was willing to do the abortion, but couldn't get any of the other folks who needed to be in the space, right? He couldn't get nurses to participate. And so even though he was willing to do it, he couldn't get the group together that he needed in order to provide the care. And that's another thing that I think is really important to remember. And then the last thing that I think is really important to remember is that even in those places that have exceptions for life, if they don't necessarily have exceptions for health, what about the person who says, I want to do this abortion now because it's going to preserve your fertility and you can maybe try again later? That's not necessarily going to be even a part of what's possible with one of the exceptions. So there's so many different pieces to the puzzle here, all of which lead to women and other pregnant folks not getting the care that they deserve.
Thanks for chiming in on that. And we got a question in the chat that I thought I'd raise now too, because the person's asking about the impact on doctors moving from out of banned states, making care less available. And Dr. Brandy, I was just wondering if you had any thoughts about the impact of these laws on the profession.
Sure. And I think it's a good tie into this conversation we're having right now about a lot of these conversations I found when I talk to other like professionals, lawyers, politicians, it's all this like hypothetical, theoretical, this is what the impact of these laws could be. Physicians, other healthcare providers are seeing this on the ground right now and are trying to have to figure this out in real time with this individual person, with this individual circumstance. And that's where all of this moral injury is coming from. It's just like it's not this hypothetical person. Like I have an actual patient that I'm taking care of and I don't know what to do. I know what medically I should do, but legally how I can protect myself and protect my practice and protect my nurses and staff. Like how do I provide the care that is in my, just like is in concordance with like my oath to provide healthcare? How can I do that and still make sure that I don't get sued and then go to jail and lose my license? So that is leading to people on the ground that are providing care making really challenging decisions about what they do with themselves. Do you stay in a state, in a community that not only, have you decided to work in because you care about this community, but often people forget that providers are humans. Like we have families, our kids may be in school in this community. And so do we leave this community that we care about because we can't provide the care that we feel is in alignment with, the care and training that we've gotten and we want to provide? So some people are leaving. I have several friends that have left different states that have had restrictions on abortion because it just wasn't in concordance with what they wanted to provide. And also like they just didn't feel safe providing care in those spaces. Other people have decided to stay. Other people are staying in their community, but traveling to other places to provide care, essentially going with their patients to be able to provide care in a state that is safe for them and for their patients. We're also seeing concerns around medical training. What does this look like for medical students, for nursing students that are applying to reproductive health fields and again, want to provide and get trained in the care that is in alignment with, the evidence and science, but don't know if they can get that if they go through their match process, which is a like legally binding agreement that you must go and get trained at this place or you don't get training. And so if they don't get matched into a place that, is allowing them to get the full type of training, like what do you do with that? And also, again, they are human. What if you get pregnant during your training in a place where abortion is restricted? Like there's a lot of things that people are considering right now and what they want to do as far as how they practice. And if we are losing providers, if people either are not choosing to go to those communities, if they're leaving communities, a reminder that not only does this space lose an abortion provider, but it loses, a laborist, it loses someone that provides pap smears, it loses that person that provides comprehensive reproductive health care. And not just like for a year or so, like this could have long-term implications for decades of what healthcare will look like in those spaces. So really concerning patterns, but understandably, people are making really hard decisions right now about how to provide care.
Yeah, I mean, the ripple effects are just, there's a whole web of impacts here. Catherine, I know you've been working and leading efforts to help providers mitigate risks, and providers, patients, and others. And so I'm wondering, can you explain a little bit about how New Jersey protects, or is to the extent New Jersey is able to protect providers, patients, and helpers here?
Yeah, I mean, the good news. Okay, so there's good news. The good news is that New Jersey's done a lot. New Jersey's done a lot to try to protect abortion care in this state. And so they've done really 4 important things. One is they've protected people's licenses. So a professional, a healthcare professional in New Jersey who performs a service, a reproductive health service of any kind that is lawful in New Jersey cannot lose their New Jersey license on that basis, cannot be excluded from the profession by being denied a license to begin with, right? So licenses are protected for New Jersey healthcare practitioners who engage in this work, so long as the work is lawful in New Jersey. The second thing is state has added protections for patient confidentiality. So healthcare providers and the people they work closely with in managing healthcare information are not permitted to disclose information about reproductive health services provided to patients unless the patient consents. There are very limited exceptions to that, but that is in addition to the federal protection under HIPAA, which most of you will have heard of. There is now state law protection on top of that for reproductive health information about patients. So that's a very positive thing. And then really, I think the most powerful thing that New Jersey has done is to protect New Jersey healthcare practitioners and other helpers, people who help patients, from interstate investigation. So let's just be like super concrete. Woman arrives in New Jersey seeking an abortion, and woman comes from a state with a ban. Let's call that state Tennessee. And that woman seeks an abortion in New Jersey, and a New Jersey healthcare provider provides that abortion. And then lo and behold, a Tennessee prosecutor sends an information request to that provider saying, I believe you treated Jane Doe for an abortion during this period. Please provide me for records. This is an official subpoena. So what happens with that subpoena? Well, here's what happens. New Jersey law now prohibits public entities, state employees, and officers and officials, including courts, from assisting with that investigation in any way. So if the provider who receives that subpoena knows to call a lawyer, and I hope that the provider knows to call a lawyer if they get a subpoena. If that person knows to call a lawyer, then they will be told, you don't have to respond, throw it away. Because if the Tennessee prosecutor wants to enforce that subpoena, they've got to go to a court in New Jersey. You aren't subject, provider, to Tennessee law. You're subject to New Jersey law. They'll have to go, and it's called domesticate that subpoena, get it in the state where the person who's the subject of it is located. And they can't get it because our courts are forbidden to assist in the enforcement of that subpoena. So there are all kinds of protections of our people against interstate investigation into their lawful behavior in support of reproductive health care in New Jersey. That's a very, very important one. And the care is defined very broadly. It covers assisting, advising, aiding, abetting, facilitating, soliciting, conspiring to provide reproductive health care that is lawful in New Jersey. The last thing they've done is also important, which is that New Jersey will not extradite anyone. Now, extradition is a process whereby a state which claims you've committed a crime there sends an extradition warrant to a state where you are located. So let's take it out of the reproductive health context. Let's say that you go to Pennsylvania and you hit somebody on the head and injure them. And then you come back to New Jersey. And Pennsylvania tries to extradite you so you can face assault charges in Pennsylvania. Okay, that's a standard thing that happens all the time. They issue a warrant and New Jersey decides whether to execute that warrant by sending you to Pennsylvania. Well, here's the thing. If that warrant is based on reproductive health care that would be lawful in New Jersey, the state will not extradite you to face charges in the state that's issued the warrant unless you performed the service there and then fled to New Jersey. And that's the exception. Otherwise, if it would be lawful in New Jersey, you cannot be extradited to the state seeking your extradition, seeking to have you face charges there. So New Jersey has done a great deal to try to protect our people from from consequences under the laws of other states. Now, I should add two things. One is These laws have not been tested in court yet. They're quite new. They were enacted several months ago. And so we don't know what our courts are going to say about them. And it would be foolish to assume that that means people are safe. And that's because there are lots of inevitable loopholes here. And what I mean by that is, you know, healthcare information, for example, that is held by healthcare providers in New Jersey is confidential in that they need the patient's consent to disclose it. But a whole lot of information is held outside of New Jersey. A whole lot of information, right? When the patient texts her mother and says, I finally found somebody to help me in New Jersey, that text, that isn't healthcare information held by a healthcare provider. That isn't subject to HIPAA. That's subject to a whole other things, and heaven knows where that what server that information is held on, and where that information is located. So we have all kinds of potential information leaks in the system that New Jersey law can't protect against. And there are, let's just say that the law about extraterritoriality, when a state can punish conduct that happens outside that state, that law is complicated. And so there are ways that states can try to punish conduct that happens outside their borders. And it's going to be about how creative and determined they are to try to rope in people who are providing care outside their borders.
Thank you. And we actually had a question in the chat about attempts being made to work with medical associations to educate them in this changing landscape. And I just want to add that Catherine and I worked on some of that last fall, meeting with providers and medical associations. And if there are folks in the provider community who want more information, Lowenstein-Sandler runs a helpline that they can reach out to. And there's information on that in the CLE materials. And we might be able to put that in the chat later too. So let me give you the second CLE code before I move on to, we'll talk about mifepristone. But the second CLE code is 167618, 167618. And so we've been talking about the criminal landscape, and it's even, there's like this other layer of the mifepristone lawsuit that we've all been hearing about, where anti-abortion extremists are trying to revoke the FDA's approval. And so before we get into the legal part, Dr. Brandy, can you help us like review the basics of what a medication abortion is and what impacts you see if it becomes restricted?
Definitely. And it's important to review not only because it's something that's relevant to this, but it's actually the most common form of abortion that happens. So over half the people that have abortions have it through medication. And typically the most evidence-based regimen of medication abortion involves two medications, mifepristone, which is what people are talking about in this lawsuit, and misoprostol. Typically you take the mifepristone and then 24 hours later you take misoprostol. The second medication causes bleeding and cramping to expel a pregnancy. And this works about 95% or greater of the time. It has a lot of benefits for people that are seeking abortion, including that they don't need something invasive. They can have this kind of in the privacy of their own home. It's something that is a little bit more private, particularly people who don't want to necessarily, if they don't have supportive people in their lives and don't want to talk about it with other people, that it presents very similar to a miscarriage process. And there's actually no test to show whether or not someone has had a medication abortion or undergoing a miscarriage process. So often I tell my patients that if they need help and they're concerned, feel free to go to a hospital and ER and, you don't have to disclose anything. And I will also just quickly add, and we may talk about a little bit more later, that there are other medications that we can use for abortion care. This is also the standard regimen that we use for miscarriage management. Like I said, we use a lot of the same things interchangeably. So there are other regimens we can use for management of these two situations, but this is what we know works the best. And so it's really concerning to potentially lose this medication because then we would be losing a medication that we know works the best. It's used for other things, and there's a lot of great data that suggests that it could be used for other things in the future, like fibroid management and endometriosis. So it's sad to consider we can lose a medication that is incredibly safe and effective not because of the science around it, but because of some political legal issue.
Which tees up my next question for Catherine, which is, can you kind of help us understand the posture of the lawsuit and the possible outcomes that we might be seeing down the road?
How much time do you have? So,
Not too
okay.
long.
Yeah, not too long, I know. So, okay, so the posture. I think most of you know from reading the news that a district court in the Northern District of Texas, which was chosen specifically because of the anti-abortion views, the very long-standing anti-abortion views of the single federal judge in the district, held several weeks ago that the initial approval of mifepristone in the year 2000 was invalid, that the FDA's initial approval was invalid, and that everything that followed was also invalid, and that mifepristone should no longer be considered an approved drug. That decision, had it taken effect, which it did not, but that decision would have made mifepristone federally unapproved and essentially unavailable, largely unavailable in the United States. But that decision was quickly appealed to the Fifth Circuit. The Fifth Circuit held something different. The Fifth Circuit held that that the original approval was no longer subject to challenge because the statute of limitations, the period in which suit was possible, had expired. But that everything from 2016 forward, all of the FDA's actions that increased access to mifepristone between 2016 and the present, all of that was invalid. So the Fifth Circuit decision would have returned us to the post-2016 status of mifepristone under the FDA, which would have meant that that as labeled, the drug was available or only earlier in pregnancy, that it had to be prescribed only by physicians, that it had to be dispensed in person, could not be mailed. So the Fifth Circuit decision would have revived all of those conditions on the use of mifepristone. And that didn't take effect either, because there was an immediate appeal to the Supreme Court. Okay, so here's what the Supreme Court did. And again, this is the good news. The Supreme Court said, all of those decisions are stayed, meaning they don't take effect. They are just held in abeyance. They don't take effect until this case comes back to the Supreme Court, which either denies cert, refuses to hear it, or accepts cert and rules on it. What that means essentially is that the availability of mifepristone is going to remain unchanged in the United States until the United States Supreme Court issues a decision in this case. That's essentially what that means. So for now, mifepristone is going to remain available on the same terms until the Supreme Court rules. And I think there's been widespread misunderstanding about that, but for now, mifepristone remains available. Now, in terms of the potential outcome, I listened to the Fifth Circuit arguments, which were last week. I think there's virtually no doubt but that the Supreme Court will resurrect the restrictions at least from 2016 on. And I think there's even some risk they'll approve the federal district court's decision as to the 2000 approval. The panel was extremely hostile to the FDA's position. And also, there is no question but that the panel believed that the physicians had standing and the organizations had standing to bring this lawsuit. And
I'm sorry, Catherine, can I just jump in for 1 second? Because you said Supreme Court instead of the
Fifth Circuit.
Yeah, so just
I'm so sorry.
To scare people.
Thank you, Dean Mutters. No, sorry. The Fifth Circuit will hold, in my view, that a whole bunch of conditions, restrictions on the availability of mifepristone should be reinstated. And that decision will remain stayed. It will not take effect until the Supreme Court hears the case. So the real question here is, what is the Supreme Court going to do? That's the real question, because that's where it's going to end up. And I have views on that, but I think we don't know yet, is what to say right now.
Thank you for laying that all out. And, as someone who spent a good chunk of my life, legal career, I should say, trying to figure out how to get plaintiffs relief in federal court, these opinions have been stunning, because they just feel so nakedly outcome driven. And so I guess, Catherine, you mentioned standing, but maybe Dean Mutcherson, can you kind of frame out a quick hit list of why these decisions were so outrageously bad, aside from the results?
Yeah, I mean, well, as a starting point, and Catherine referenced this as she was starting to talk, the fact that this even ended up in this district in Amarillo, Texas, just from the beginning. I mean, people forum shop, right? I get it. But to target this one district because it would get in front of this judge, and that this judge would issue what is quite frankly a bonkers decision, right? I mean, the science is bonkers, just all of it. So they were very particular, and there's nothing surprising about that, right? I mean, this was a very meticulous campaign from the beginning to overrule Roe. So you would expect that kind of stuff to continue. So that's really wild. And then I think another piece of it that's really wild is the separation of powers issue, right? The idea that, and this is a very scary thing, right? I mean, one of the things that I think people need to think about is there's all this stuff that's happening in the context of abortion that has potential to impact lots of other ways in which we live our lives. So for instance, the idea that the agency expertise that we expect from the FDA would be overruled by whether it's the Fifth Circuit or Judge Kaczmarek in Amarillo, that's extreme, right? And we know that this court, the Supreme Court, is willing to do very extreme things. And we know also that they've accepted cert on a case that is about deference to agency determination. So what does it look like in a world where we decide who cares who the experts are? There's some judge in Amarillo, Texas, who disagrees. So there are lots of little bits and pieces of this that I think are deeply problematic, lots of separation of powers, lots of federalism issues, forum shopping issues, all of which ultimately could have a really negative impact, not just in the abortion sphere, but much more broadly.
And can I just revisit standing? I know that the audience is out there thinking, tell me more about federal standing, right? Because that's kind of that's something everyone is on the top of mind all the time. So standing is about who has the right to bring a federal case, right? Who can bring the case? And normally, in order to bring the case, you have to show that you are injured by whatever it is you're challenging. I am bringing the case because I am hurt, and not, by the way, in some vague way that everyone is hurt, but that I am personally hurt by the thing I'm challenging. So one may ask, how are these doctors who are anti-choice doctors functioning in anti-choice organizations, meaning they do not perform abortions, right? How are they harmed by the FDA's approval of mifepristone, you may wonder. And here's what they said in the Fifth Circuit arguments last week. They said, A, we're harmed because there are situations in which we may have to complete incomplete medical abortions in violation of our consciences. And B, we're harmed because the aftercare for patients who've undergone incomplete or unsuccessful medical abortions makes us feel complicit in an action we object to based on our consciences and our religious beliefs. And the court said to the FDA, essentially, do you accept that? And the FDA said, we in no way challenge the religious or conscientious beliefs of the doctors. And I understand exactly why they said that. Deeply unpopular and very, very high bar to suggesting that these are invalid bases on which to proceed. But I just want to I want to say, while the FDA may not challenge it, I am pissed off about it. Okay. And here is why. Doctors treat people all the time who do things that the doctors might not agree with, right? Doctors treat patients who overdosed on drugs. They treat patients who attempted suicide. They treat patients who do they treat people who are habitual smokers and have developed lung cancer. They treat people who are wounded in fights. They treat people with gunshot wounds. If doctors can say, look, man, I really do not like drug use. And I'm on staff in the ER, but I feel like if I'm going to help this overdose patient, it makes me complicit in drug use. And that is offensive to my conscience. And therefore, I think that the drug, whose name I will forget, but it begins with an N, and Dr. Brandy will know what it is, that people used with drug overdose patients, I don't think that should be approved, because I don't like drug use, and I have standing because of that to go into federal court and overturn the approval of the drug. I ask myself, is that insane? I mean, first of all, is that as a matter of medical ethics, and Dr. Brandy, I'm totally, yes, right, naloxone, right. I mean, I'm totally putting you on the spot here, but like as a matter of medical ethics, right? You treat the patient who you're not like, man, this person smoked. I don't approve of smoking. I think smoking is a public health nightmare. It costs this country hundreds of millions of dollars. And people who do it, even though they now absolutely know the health risks, people who do it, I don't know, like I'm not treating this lung cancer. That's nuts, right? And why are we, I mean, it's nuts. And why are we allowing, right? It is one thing for a doctor to say, I will not perform an abortion. Okay. I mean, there are circumstances where I wouldn't accept that either, when it's an emergency and no one else is available. But on the whole, absolutely. People who want to opt out should opt out. But I won't treat someone who appears with complications because it makes me complicit, or I will treat them, but then I have the standing to challenge the remedies of it. It just strikes me that something is very wrong with that setup that hasn't been said, because of our fear of taking on the claim that this kind of thing is based in conscience and religion, when I'm not sure that's a viable thing to defend if you choose to be a doctor, right? Look, you want to go be a Christian Science healer, knock yourself out, right? But you're going to be a doctor practicing in the emergency room, and you're going to be like, I don't like this dude. Like, he seems to have done some stuff I don't approve of. What? Right? There's something deeply wrong with that has not been exposed, I think. So that's my rant. That is my little rant.
I mean, I'm right here nodding with you on that the whole field of medical ethics would be entirely in agreement with what you're saying, that there are some permissions for providers that have conscientious objections to certain types of care. But as a whole, we show up and we take care of whoever shows up at our door. That is the whole thing. And most people can't be healthcare providers without having that core tenet as part of the reason why they're, providing this care. I do also want to point out to Dean Mutcherson's point about, the plaintiffs have also said that if we continue to allow mifepristone to exist, that ERs will be flooded with people that are coming in with complications. And that is blatantly not true. It's borne out in the science that, like I said, a medication abortion is generally 95% or better as far as effectiveness. And the rate of a complication, or the rate of someone having to actually go to the ER, is less than 1%. And in fact, it's like less than 0.1%. It's an incredibly rare thing to happen. I don't know where the people in this lawsuit got their data, but it's really disheartening to think about both the ethics behind it, but also just like the facts behind a lot of this case.
And Dr. Brandy, just to be clear, right, if someone's completing an incomplete medical abortion, right, if the contents of the uterus have not been expelled, is there, in how many cases is there still a living fetus?
Pretty much not existent.
Right. So it's not like it's not like these docs are performing an abortion anyway. They're emptying, they may be helping to empty the uterus of somebody who had an abortion, right? But this is why I think that there is this kind of like, there is so much reluctance to take on what that actually means and to think about what it means for there are all kinds of things we all disapprove of, right? And what that means for medical care in public settings. You know, again, if people get taken to the emergency room that's near where they are, you end up seeing the doctor you see. It's not like going to a restaurant. It's not like, I don't like this one, I'm going to go to, it's not like that, right? And we have to just take better account of what this means in real life.
Yeah, and one of the legal arguments they're relying on too is this very old Comstock Act. And Lauren, we don't have too much time, but I was wondering, thinking about Comstock as this like looming old law that criminalizes access to abortion related tools, I guess, right? Could you just tell us a little bit about how, if the resurrection of the Comstock Act might impact the landscape?
I mean, so just adding to another aspect of this that is, beyond the pale and entirely ridiculous, but is now a reality that we have to deal with. The Comstock Law is a 150-year-old federal statute from the 1800s. Brainchild of Anthony Comstock, who was called an anti-vice crusader. He worked as a U.S. postal inspector. He founded the New York Society for the Suppression of Vice. And this was a person who was, I think we could call him obsessed with leading a campaign against criminalizing sex-related activities, things that could be cast as obscene, and making these illegal activities and trying to marshal the might of the federal government and federal law enforcement to go against those kinds of activities. And even at that time, those views were seen as extreme. But he was able to leverage his power politically and financially to lead that campaign that ultimately resulted in these laws. And the laws this law makes it illegal to send anything considered obscene, lewd, or lascivious through the U.S. Postal Service. And it includes every article, instrument, substance, drug, medicine, or thing designed, adapted, or intended for producing abortion. And so that's the law that's being used by the litigants in the Mifepristone case to claim that separate and apart from the argument that the approval process was shoddy and cursory over decades, that they're saying that this approval process and use of this drug in the mail violates this federal law. So just to be clear, the law has never been interpreted to ban lawful abortion, or to ban the use of medication in lawful abortion. And the DOJ has made very strenuous arguments and is continuing to make arguments that the law cannot be interpreted to mean that. But certainly it was raised before the district court. It was echoed in the Fifth Circuit's version of consideration. And there they tried to say, we don't have enough time to fully delve into the issues, but they did certainly give a lot of reason to believe that they're treating that Comstock argument taking that Comstock argument seriously. And so I do think that certainly those arguments are dangerous because they go against longstanding understandings of the Comstock laws, and it would go past just the implication for this one drug in particular, right? So if it would go, and it also, based on the way that the Fifth Circuit seems to be interpreting, wouldn't require, in a criminal prosecution, proof that an abortion actually occurred. It's just, is this a thing that could be used and is being sent in the mails to possibly perform abortion. And so that would have broad scope and certainly change what is accessible in states where the law is intended to permit and protect abortion care. I think another reality of this is that even if the Supreme Court ultimately were to decide to not make any determination about the applicability of Comstock here, it's not something that can be dodged. The cat is out of the bag here. And if the court is to duck the issue in the Miffy case, we're seeing it pop up in more and more settings. Jonathan Mitchell, you've heard of him, the legal strategist behind SB 8, the Texas near total ban, which authorizes civil prosecutions by private citizens for people who are alleged to have accessed or helped others access care. He is going around in other jurisdictions, shopping municipal ordinances as good legislative vehicles to bring up this law again. And he's pretty much said, if not, I believe explicitly, that the goal is to make Comstock the law of the land. So we have to be very, upfront about this possibility. And the Biden administration has continued to be very strong in this, making clear that there's no present day risk of enforcement, but obviously that doesn't speak to what could happen should the administration ultimately change. So again.
Yeah, thank you for that context, because it's horrifying to think that a law passed before many people could vote even is going to, is trying to be resurrected. So I know we're getting close to the end of the hour. I guess I'd just like to throw it out. Do folks have recommendations for our attendees here on steps they can take to work on abortion access, protect and defend it?
I have three.
Great.
So one, following up on what Lauren just said, contact your Congress people and tell them that Comstock could be amended, right? I mean, this is actually not that hard to fix the Comstock issue. Second thing that people can do is, if you are a person who has money and you like to give money to things, give to abortion funds. It's nice to give to the big organizations, but abortion funds are on the ground and they're helping people on a daily basis. And the last thing is, if you don't have money, but you have a car, think about whether you could participate in a practical support network. So I think a lot of folks would be surprised to find out that sometimes what's keeping somebody from accessing abortion is they don't have somebody to pick them up and drive them home after the procedure. Right. So getting involved in that way can also be incredibly useful. Open up your home to somebody who comes to Jersey for a 2-day procedure, so they don't have to pay for a hotel. Those things actually can be life-changing for people.
Thanks for those great tips. Does anybody else want to chime in?
I'll just say the Comstock needs to be repealed, not amended. That's what you're going to say to your Congressperson. Repeal this.
I don't want to ask too much of this Congress, right? They seem to be in the midst of so much struggle. Just even fixing a little bits and pieces at this point might be all we can ask for. But yes, repeal would be the smart one.
Great. Well, I want to remind folks in New Jersey that you can contact your lawmakers. We have the Reproductive Equity Act, which is going to fill in a lot of gaps on access by providing removing some financial barriers to care that still exist here in New Jersey, insurance requirements, providing support to providers to build out infrastructure, providing some more legal protections to folks. And so we just sent a link to our action page on that. So I really encourage people to fill that out, but also to call your lawmakers and let them know that reproductive health and abortion access are important to you. They need to be hearing from people about this being top of mind. And I just also want to point out, we have some resources in the materials from the Attorney General, from Lowenstein-Sandler. ACLU has materials about abortion rights and FAQs and things like that. And so you educate yourself, let people know that you have access to this information in case there are questions in our communities. It's really important to be open and vocal about sharing accurate information about what's available. So with that, I'll give you the final CLE code. It is 155425. We're going to put another link in the chat for the evaluation forms. Please get them in as soon as possible, but we're closing the evaluation forms on next Tuesday, May 30th. So I want to thank our panelists for sharing their expertise with us this afternoon, to our sponsors, to everyone behind the scenes who made this webinar possible. As we've heard, there's a lot of challenges ahead, but we have some amazing people leading us in this fight. And so I hope we'll all leave here energized and ready to engage on these issues. So thank you, and I hope everyone has a wonderful afternoon.
Thanks, everyone.